Yeah, I just remembered. I was like, okay, that was a bad move.
Craig, we just discovered something really awesome about you. You actually give out your cell phone number to patients.
On your machine.
On your machine, you give out your cell phone number to patients.
Sure.
I'm amazed.
I mean, how else are they going to call me if they need something?
Wow. That is dedication. Most people don't do that.
People don't use an answering service?
A lot of ODs don't know.
Amazing.
I'm the answering service. I mean,
amazing to me.
You know, I figured that out years ago.
Wow.
You are full service, my friend.
You are.
So, I mean, I've talked about that several times. You know, I mean, I think you got to answer the phone. You know, I've given several anecdotes about me answering the phone on Saturday or Sunday. You know, and it's a big deal.
Well, patients remember
and
that.
No one's going to triage. Well, it's just, you know, no one's going to be able to triage some emergency better than you.
Right.
I mean, I've talked to docs where they say my office manager will decide if I need to come in. Well, there's no way your office manager is going to do that better than you. Just take the call. I mean, that's how we make a bunch of money. I mean, just, what's the problem?
Do you live near the office?
7 minutes.
Oh, well, see, there you go.
Easy.
Yeah. If you live 45 minutes away, you might not be so anxious to go in, but...
No, but it's not something you do every day or every weekend either. I mean, you know, between me and my partner, we average 2 or 3 after-hours emergencies a month. I mean, it happens, but it's not constant.
Right.
And since there's 2 of us, we split it, so it's not a big deal.
Right.
So this
So
is
what's
a
up?
lesson.
What are we talking about?
So we're just BSing with a lot of folks, but I want everyone to know, you know, so everyone knows you, but if you don't know Dr. Thomas, I don't know where you find the time to do all the stuff that you do. I mean, you literally, you cram like 3 lives into one. When I go on the site, when I go on ODwire and I see the cases that you put up, I'm just shocked. You know, it's kind of amazing the things that you're doing. So I don't know where you find the time these days to do all this
Maybe
stuff.
he doesn't sleep.
Yeah, maybe. Do you not sleep?
I get a good 4 hours a night. I'm going to talk to that. I'll be pre-diabetic in a minute. Man, I heard Paul told me you guys talked to him. You know, we had this killer course, man. It was the bomb. I mean, it was so good. I can't believe that my part didn't come through.
I know. So, you know, yeah, it's, you know, hopefully you guys can re-record it and get it out there. Because, you know, most people only watch this stuff on demand, right? The majority of folks watch the recordings. They don't watch it live.
So you aren't really missing a whole lot of people there. So you guys are going to get together and re-record?
Well, yeah, we're doing a meeting together next month in LA, so we might try and do it then. But, you know, it's hard to do that. It's hard to recreate it. You know,
right.
We had a real good vibe going. You know, we've lectured before, so it was kind of, you know, the back and forth, which is hard to do, you know, when you're not standing next to the person.
Right.
But it just came off real good. I was really happy with it. He was too. I was, you know, I'm disappointed that we couldn't get it right. And I was joking with him. I said, man, we got like 8 college degrees between us, and we need technical support to make a video.
Right. So if you guys do manage to record it again, though, not only will we put it back up on CUwire, I'm going to put it on ODwire as well, and we're going to remarket the thing via mass email to all 21,000 docs, because, you know, I saw the original one that you guys did, and it was great. So I think everyone would learn a lot by seeing it.
Yeah, it was good. You know, the part that I was sitting there listening to it the other day when he said it didn't go through, and all I kept hearing was, you know, after like 8 minutes of silence, then Paul Taus would come in and said, "Craig, that was a great point. Excellent question."
Oh man.
I'm like, "You're killing me, man. You're killing me." So we'll try to recreate it. Great.
Yeah. So you have another talk coming up today, though, too, that also looks really interesting.
Yeah, it sounds really good.
Well, it was kind of an offshoot of doing the diabetes lecture, because so much of what I'm doing now, you know, is diabetes related, and you almost can't have enough technology when you understand all this neurodegeneration and trying to get the subclinical vasculopathy. So you really need everything, and I've seen that, you know, even if you have an OCTA, your multispectral imaging is still important. If you have the multispectral imaging, you still need the OCTA, because they're looking at different stuff in different ways. And to really be comprehensive and do the absolute best job that's possible, you know, you need both kinds of technology in addition to all your regular technologies. So It's really been interesting learning about it the past year. I mean, I started doing multispectral imaging 3 years ago, but a lot of the new information has changed the way I use the technology and incorporate it. And before, it was mostly kind of looking for macular degeneration and the occasional, pre-diabetic. But now it's really heavy focus on the diabetes detection with the multispectral imaging. So it was good. And again, I'm really kind of disappointed because probably 20% of that diabetes lecture was also talking about how to incorporate multispectral imaging into your diagnostic workup.
Right.
But it'll be good. Again, I broke it into 4 sections, real simple. It's kind of 4 different conditions. We'll hit the insulin resistance, the regular diabetes, the macular degen, and a little bit of choroidal nevi. We don't think about that stuff, but, it's pretty common. I mean, it's 5-10% of the population. I see them all the time. So I thought that would be kind of a good refresher on that. So I think it'll be very good. And my goal is to expose people to the technology. Still I'd go to a meeting and I'm trying to get the terminology right where people say, hey, what do you know about multispectral imaging? What's been happening is people say, hey, what do you know about Anitas?
Right.
Anitas is the company that makes the thing, but that's not what it is. It would be like me going up to one of our colleagues and say, hey, what do you think about Zeiss? Hey, what do you think about OptoView? Well, OptoView makes, 5 different machines,
right.
So you can't go by the manufacturer. You need to go by the technology. It would be, hey, what do you think about OCT angiography?
Mm-hmm.
Well, there's 3 or 4 people making those. Now we can talk about it. It's not a company. So that's kind of the first thing is when I still ask people, I say, hey, have you done any multispectral imaging? And probably 8 times out of 10, it's like, well, what's that?
Right.
And I'm like, come on now, we got to kick it up a notch. It was 2018. We got to kick it up a notch.
Craig, we spoke.
And be all on the same page.
We spoke to Paul yesterday. He didn't. The lecture didn't come through. We had a very interesting half hour, and he says he works directly with endocrinologists right across the street with a large group. So my question to you is, how much do the primary care and internal medicine people and the endocrinologists know about this advanced technology that Conan has that they're sponsoring here? But this we don't have to worry about COPE. We can talk about these things here. So how do you spend any missionary time speaking to MDs about this?
And that's an excellent question, Paul. And right now the answer is no. I had a terrible experience when I acquired the lens fluorescence biomicroscope, that instrument that was made by ClearPath. That thing was really cool, where you were looking for these glycosylated end products, these AGEs in the lens. And so I bought the machine. It was real slick. I'm trying to identify people that have diabetes that didn't know they were diabetic. And I started picking people up. We would send, notes to the family practice guys or the endocrinologist. And not really endocrinologists, almost by definition, these people are treating diabetics. It would usually be family practice guys or internists, and they'd be working on high blood pressure or cholesterol. And I'd send a note, hey, I think this guy might be diabetic. Would you please check his glucose, check all this stuff? And I'd get these nasty, hey, don't interfere with the practice of medicine. Hey, get away from me. You're just an optometrist.
Wow.
Hey, you don't know what you're talking about. So, I mean, it was almost 90% rejection of me trying to introduce the technology and get the medical doctors to alter their practice patterns. It was very disappointing. And after a while, I gave up because it was creating high drama with the patients, because then I was putting the patient between me and their medical doctor. And as good as I am, and I'm real good, man, they usually choose their medical guys.
Sure.
They usually do. I mean, I got to tell you, they usually choose their medical doctor over their optometrist.
Right.
Probably 80% of the time. And so I was swimming upstream with one hand, and I just like, okay, I'm gonna let this fight go. So I actually stopped using the machine and stuck it in my garage, even though it produced clinical benefit, because I just got tired of fighting the medical guys.
Right.
But now on this new stuff that I'm doing with the OCTA, angiography, and the multispectral imaging, I just run a parallel course. I don't mess with them. Right. They're not going to understand. I hate to say it. I hate to be negative, but you guys know how I feel. If I started sending notes to these guys saying, hey, our mutual patient has subclinical diabetic retinopathy that I picked up with this fancy $70,000 OCTA machine, would you please get more aggressive with their treatment? They're going to say, well, let me send that patient to an ophthalmologist to make sure they have diabetic retinopathy. And if that ophthalmologist doesn't have the same technology I've got, or if it's not a retina specialist where they're going to do an intravenous fluorescein angiogram, they're not going to see anything. And so then that second opinion is going to debunk my correct opinion. And again, I've been through it. I started it, 2 or 3 times. Guys started going left on me. I'm like, okay, fine. So I double back and I just run a parallel course. So I tell the patient, hey, I've got more technology than they got in the space shuttle. You can see that for your own eyes, okay? You with me on that? Yeah, Doc, we with you. We know we're in the best place in town. Okay, I'm 5 years ahead of your guy, all right? It's not his fault. It's just the way it is. I'm like that, okay? That's why you come in here. So I'm 5 years ahead of your guy. We're going to work it like that. I'm going to tell you the truth. I'm going to tell you what's going on. And sometimes your guy might not agree with me because he's going by 22-year-old guidelines or she's going by 22-year-old guidelines. So if I don't see any blood in your eye, I'm going to tell your guy that you're normal, okay? Because all it's going to do is cause drama. If I see stuff that no one else could see, I'm going to tell you, and we're going to start working on it, okay? You got me? And everybody buys in because they like me, and I'm good at this stuff. So that's an excellent question. And unless the guy is like Paul Chauce's guy, where they're intimate and next door and been working together for 20 years, and all Paul Chauce has to do is say, hey, I've got a guy with subclinical diabetic retinopathy, and the internist that he's working with says, okay, fine, what do you want me to do? I don't have a lot of guys like that around here. And if you don't have one working in your office or next door to you, you're not going to have one either.
Right.
I think you're going to have to do it like I do.
But what about a
nutritional supplements?
Right.
Go ahead.
But what about a functional test, right? Because Conan's tests, these are functional tests, right? You're getting people with decreased contrast sensitivity and so forth. I mean, that's something that, do they reject that too when you show this to them? Like, hey,
they reject it all.
That's crazy.
They go by visual acuity
wow.
and observable fundus findings. They go by the guidelines from 22 years ago.
Wow.
Period. And until it changes from a medical legal sense, or there's some new study that comes out where it sets the peer-reviewed literature thing on its end, then that's the way these guys are. I don't have the wherewithal to fight them. So, again, I just run parallel. And I tell the patient, hey, we're going to run parallel. You don't have to tell them what we're doing. You can if you want to. I don't care. I ain't going to tell them nothing. If I don't see any blood in your eye, I'm going to tell them you're okay. And then we're going to do all this other stuff, all right? If they got 20/20 vision, but I see an abnormal ERG and decreased color vision and reduced retinal sensitivity on the threshold field, and they've still got 20/20 acuity, I'm not telling that guy anything. He's not going to believe me, and he's not going to do anything different. So I'm going to have to do everything different, which I got no problem with. That's what I get paid for. So that's, again, man, top-notch question, but that's how I do it.
So basically, just like the AOA should be teaching the public what an optometrist is, the instrument companies that make this should be going out to the internist and the endocrinologist to talk about their products as well. It's not your job to do it, but certainly the people that are selling these instruments should be teaching this to the people that are giving you a hard time.
Well, we've got to be careful of that because we don't want, you got to be careful that, first, will they be interested in hearing something like that? I mean, they don't want to see their own sales reps, let alone something for an eye care product that they aren't interested in. And then you also want to make sure that you don't have people practicing eye care who don't know what they're doing.
But sooner or later, the ophthalmologists will be doing the same tests that the optometrists are doing.
Oh, of course, yes. I misunderstood.
To their colleagues, their medical colleagues, so they should be on some sort of level playing field when they get this information.
But if you're a primary care guy, are you going to see a rep from an instrumentation company for eye care?
Well, but maybe they could just send out some sort of circular, something to mention.
Would they read it? Would they care?
The problem is deeper.
In my experience, the internist and the family practice guys are going to default to the ophthalmologist that they hang out with. That is my experience.
Yeah.
And also in my experience, if the ophthalmologist is a busy surgical ophthalmologist, then that dominates their thinking, and this almost is, I don't want to say secondary, but it's not, on the top 3 things, it's number 5.
Well,
so they don't care about it as much as long as they have surgery to do.
Right.
So they'll go into what if I go to one of these guys, I'll say, hey man, I've got this new dark agatometer, and it picks up functional vision loss in a person with diabetes 5 years before I can measure it any other way. And they'll say, well, what are you going to do about it? I said, well, I'm going to put them on nutritional supplements. If I can't give them more insulin, then I don't care. If I can't give them a third oral medication, I don't care. They're just not ready yet. And so just don't fight them. Just go back to whatever's best for the patient. I know what I'm doing is best for the patient. I'm good enough to convince the patient that what I'm doing is best for them. It works probably 90% of the time. The other 10%, I let it go and just fill that spot with somebody else.
But a lot of it seems to come down to trust, though, right, Craig? That the patient trusts what you're saying.
They got to trust me. They got to trust me. I mean, I'm the Jedi Master over here. It's Jedi mind trick left and right. I mean, I'm doing it all day long, and I'm doing it on purpose. I'm not even subtle with it. Okay, I'm training them. Okay, then I got to. If I don't, I'll lose all my patients.
Right.
I'm totally medical. I just sent a foul letter to this internist about 15 miles from my office. I only know him by me sending diabetes reports and stuff. And this guy, I saw one of my patients, a patient I've been working on for 20 years, patient with an aneurysm, patient I diagnosed with glaucoma. I take care of her husband. I take care of her daughter. I mean, this lady, if she broke her finger, she's going to call me and let me know she's going to be late for the appointment. That's the kind of relationship we got. So she's in the office with her husband, who I take care of, with this knucklehead internist. This is about 3 weeks ago. And I see the lady every 6 months because she's got an aneurysm that we're monitoring, and we always do visual fields. And so some kind of way it got mentioned, and this knucklehead internist sent my patient to the ophthalmologist that works in the building with him. And when the lady tried to protest, and I was a little disappointed in her for not protesting harder, she said, hey, I got a regular eye doctor. I go to him all the time. His name is Craig Thomas. And she said, this knucklehead internist says, well, that's okay. I've heard of Dr. Thomas, but I would recommend that you go get a second opinion from this doctor here. And, she did it. As good as I am, man, these medical guys, they got that mojo. And when they tell our patients to do stupid stuff, they usually do stupid stuff. And so this lady went and saw this ophthalmologist, had a visit she didn't need to have, had tests that I'd already done, spent Medicare money that didn't need to be spent, and then still came and saw me on Monday for her regular appointment. And she walks in with this visual field that the ophthalmologist did a week earlier. I'm like, what is this? She goes, well, I went to this other eye doctor. And I'm like, what are you talking about? And then she told me the story. I was like, I can't believe how good I am at this stuff, and I still got to go through this. I still got to go through it. It's incredible.
Did you get a report from that other internist?
Huh?
Did you get a report from that other internist or from the other ophthalmologist? What did he find?
No, of course not. No. Her visual field machine is just like my visual field machine. There's no difference. Right. Her technician's no better than mine. The visual field test is the visual field test. No, I just sent a foul letter to the internist. I said, hey, I just said, it was like, 3 sentences. I said, I don't appreciate that you sent one of my patients to get an unrequested and unneeded second opinion. I promise you I will return the favor on our next mutual patient.
Oh.
That was the letter.
Oh, my gosh.
Do you anticipate a reply?
I don't care. I said what I wanted to say.
Craig.
Then when the patient told me what happened, I dropped a couple of F-bombs and went left. I'm like, okay, that's fine. And Dr. Thomas let it go. And I said, I'm not going to let that go. I said, she better be glad I ain't driving down there. That's with my livelihood.
Oh, my God. That's hilarious. So, Craig, one of the other funny things that I think there's a problem, you're doing something about multispectral imaging, and I don't want to speak ill of any company, right, because obviously that's not a good thing to do. But I think one problem, too, is that the company behind this particular kind of imaging has not done a really great job even of educating ODs. Forget about MDs, right? Because, you're at a trade show and you see these images that this thing spits out, and they're incredible. But so many people have no idea what it is, to me, which is shocking. I mean, this has been around now for how many years? 5 years, maybe? But so few people really know about
5 years, yeah.
Yeah, so...
Yeah, I mean, that's an excellent point. And to their credit, they've recognized that over the past 6 to 12 months. And again, let me give my disclaimer. I do not work for Anitas. I'm not a paid consultant. It's nothing like that. I'm just trying to take care of my patients. But what I've seen is that, practically everybody that was in the upper echelon of the company has been turned over. So people have been reassigned or new people have come in. They fortunately for them, I think they made a large sale to the Chinese. Gave them pretty significant boost in finances, and they are, again, I don't want to speak for them, but just from what I know, talking to the guys, they are trying to rededicate themselves and to tell the optometric and ophthalmologic community what this technology can do, and hopefully, again, my class will be a little bitty start to that. And I told them, since you brought it up, I mean, I didn't know if we were going to go here.
Sorry.
When I agreed to do this, I mean, Adam and I were talking, a couple of months ago. I said, hey, man, I'm really doing a bunch of stuff with this multi-spectral imaging. Let me give a course. So I told the guys, hey, man, I'm going to give a course on your technology. And they were appreciative. And I said, send me what you have, with all the lectures that you've got, whatever paid consultants you had speaking for you. I want to review everything that's been out there, because honestly, as I started my research, like I do for any presentation, I start doing internet searches, trying to find whatever peer-reviewed articles I can. Man, there wasn't a whole bunch of stuff. I mean, I got 7 or 8 good articles, but it ain't like I had 50 to pick from. I mean, I probably could have delved into some Arvo stuff, but there wasn't a lot out there just hanging out beyond just introductory stuff. And so I got a hold of all their stuff. They sent it to me, and I spent quite a few hours looking at it. I mean, this is what I do. So I mean, if I'm going to be a paid speaker for X company, I still need to know about Y company's technology. So
Right.
I mean, I've got to immerse myself in it. And so I looked at all the presentations, and without disrespecting anybody, they were not the best. And they spent all the time. I mean, it was a bunch of 2-hour lectures by 5 or 6 different doctors, and they spent all the time kind of highlighting these fancy multi-spectral images that were so new. I mean, you can get 15 different colored images, and all the lectures highlighted, oh, look at what this machine will do. Look at what this machine will do. And it was all this weird stuff, just stuff you see once every 10 years. And I'm like, man, this is way wrong. This is not how you introduce the technology. The way you introduce it, I think, is the way I'm going to do in this class, is you pick 3 or 4 things that everybody sees, and you say, how can this technology help me take care of people with these problems? And none of the previous lectures really did that. Mm-hmm. So I think, that hopefully if they like this, they're going to start going in a different direction with their lectures and their consultants and their speakers, and focus on the stuff that I'm going to talk about. Because I think if optometrists see that, then they would see that there's patients in their practice where there would be benefit to having the technology, and they could try to figure out a way to make it make financial sense, because the technology is expensive.
Right.
It's not really hard once you understand it, but again, it's not inexpensive stuff. You got to spend some money, and most people, they got to make that work. If I got a $1,000 payment every month, hey, I got to make $1,000 before I start saying hi. You got to figure that out. And the way they were presenting it is that you would never see enough. You wouldn't see it in your head. The patients that you could use the technology on, or it was always presented like all of an Optos kind of thing, where it was a screening procedure that you charge cash for. And I know doctors that do that and are extremely successful with it. One of my buddies, he's got one, and I just can't believe how much money he makes with that thing. It's like $150,000 a year on screening fees.
Right.
But I don't have a practice like that, and I'm not in that part of town. I got to figure out a way to do it medically. The benefit of it is that you could, like almost all the other technologies we have, you could do it. If you had enough people with enough money, you could just charge cash, just like dentists and everybody else does. But if you understand it, and have a practice with enough pathology, then it's relatively easy to generate enough fees to cash flow these kind of things, as long as you understand everything. So again, I'm going to try to start that educational process today, and my goal is to expose people and honestly to get people to acquire the technology. I want people to buy technology. I think it's better for the profession. I think it's better for our patients. It's better for the industry. It's better for Optometry Times. It's better for ODwire. You guys know, man, everything kind of sort of, I don't want to say it revolves around this, but the vendors are a critical component to what we do. And we've got to recognize that those of us that can support them have to support them.
Sure.
Or things are going to change, and I don't mean for the positive.
Well, this is probably the only instrument that I've ever been super frustrated with when you go to an exhibit hall and the images pop out at you immediately when you see it, right? You're just walking around and you're this dusty part of the back of the exhibit hall and you're like, holy smoke, look at this thing. And you just have to wonder after all these years.
It's overwhelming.
I mean, it's crazy.
It's too much.
Yeah.
It's too much information. And that's why I limited my thing to 4 different patient categories. You could go 20 different categories.
Yeah.
It's too much to absorb in an initial setting. Because there was no multi-spectral imaging lectures in optometry school in 1979.
Right.
Nobody knows about this stuff. So you got to learn it as you go. And that's a challenge. That's a challenge with a lot of new technologies. These companies have it all figured out, but the people that they want to buy machines, they're still practicing like it was the 80s. And I've been on a mission since I joined ODwire to try to stop that.
Yep.
So I'm going to keep going.
All right. Well, very good. I'm looking forward to your lecture, actually. I haven't seen it yet. I kind of want to watch it now. I want to see what you actually do with this thing. So,
yeah, I think that I'd like to see you lecture in person as well, because I think you'd just be a very dynamic lecturer. So I think that would be great.
It'd be cool. I mean, it's a different, I always have a 5% spoilage factor. You guys know that. So there'll be, if there's 100 people in there, 5 of them not going to like me. But the other 95, they're going to be pretty happy most of the time.
Well, your class is going to start, let's see.
Oh, yeah.
It's going to start in 2 minutes.
In 2 minutes. So
you'll be there
and then what do? I need to sit and listen and answer any questions or anything that scrolls up.
Exactly. Of course, now you've given out your cell phone as well, so feel free. People are going to be calling out.
You're going to hear from folks.
Yeah.
It was so cool to talk to you today, Craig. I'm glad that I had the opportunity.
It was great.
Oh, absolutely.
Thanks.
It's always fun.
All right.
Craig.
Thanks so much, Craig.
We'll talk to you soon.
You're welcome.
Bye.
Okay.
Bye.